Okay, next up, Tom Priselac.
Let's see here. So good evening, everybody. Glad and happy to be with you as well. I think Diana hit all the right points, so let's just move to the Q&A. Like Don, I struggled with the assignment for the next 12 months, and so I've taken my own poetic license with the evening, and hopefully it'll come close to what we were asked to do. One of the things we were asked to do is to begin just to make a quick look back on the last year, and I'll try to do that very quickly. I think there were a series of environmental factors that I think are worth commenting on. There's some comments about the cost trends and the quality trends. With regard to environmental factors, I guess the one I would refer to is the exchange and the development of the California exchange, which on the commercial side, I believe has about 1.3 million enrollees at this point, which is at the lower end of what I think was expected. And so you can infer from that whatever you'd like in terms of the progress that the exchange was making. The other part of the past year, I think, was that surprised a lot of people, where the number of people now enrolled in Medi-Cal. Some 1/3 of the population of the state of California now enrolled in Medi-Cal, which has, I think, a lot of implications in terms of the statement it makes about the socioeconomic status of the state and implications for things like healthcare status, given, as we all know, the implications of socioeconomic status for one's healthcare status. This past year also saw the implementation of the California Dual Eligibles Project. Those of you not familiar with it, those are on Medicare. These are poor Medicare patients who have been basically, large numbers of them have now been moved into Medi-Cal managed care networks. That implementation was not entirely smooth and had its own challenges. It does raise, among other things, the question of whether or not these patients had been moved into Medicare Advantage networks as opposed to Medi-Cal managed care networks, and what implication that might have had on the difference. Commercial insurance market dynamics, I would say, we're starting to reach the early childhood, perhaps, of the post-ACA world. I think there have been evolutions and development in the networks. The networks are broadening somewhat, and there's a certain stability. I don't mean to suggest that it's finalized at all, but certainly more stability than the prior year. And on the provider side, as has been referred to, there's really an evolution that's going on away from hospital organizations and physician organizations to what I think is rightfully called healthcare organizations. And that's happening around the state to significant degrees. On the cost side, I think there is good news on the cost side. All of us would like to see cost decline. But we've been on several years now where the cost trend has been much more moderated from previous years. And in last year, I think went up a little bit over 4% in terms of total spend, while a lot more people are now enrolled. And so that has to be considered as well. And then finally, on the quality side, if in the interest of time, I can go into this in more detail in the Q&A. But I would say that on the quality side, hospitals and physicians are fully engaged in this question. There's an organization called the Hospital Engagement Network here in California, includes some 400 hospitals. There's been a collection of activity that they've undertaken that have made real and significant progress in a number of quality measures, and among other things has resulted in some 9,000 lives being saved as a result of improving quality and safety and saving some $70 million. So that's a quick look for the year that we just finished. Maybe I even bailed out more, Don, than you, so I can't predict the future for the next 12 months all that well either, but I can identify a couple of levers that I think will be the basis on which more specific things can be expected to occur. So the first is the next round of ACA implementation, and the question there is whether or not there will be, in fact, more success in getting more people enrolled in the exchange that has occurred to date. And there's now this new introduction, the current interest in expanding coverage for those who are currently not eligible for the exchange and what the implications of that might be. With regard to the deployment of value-based payment models, I would just echo the comments that Don made, that both on the government side as well as on the commercial side, the movement towards more and more value-based payment systems of one type or another is going to continue. I would observe that the movement to capitation has not been as dramatic as many people expected. And so I think we're likely, for the coming year at least, to see a continued mix of capitation and other value-based payment models. And to his point about the federal government being a market mover with regard to hospital payment, CMS's announcement this past year of wanting to have, I think, by 2019, 80% of all Medicare payments in a value-based payment model, I think will be a significant issue for the field. And then finally, as Diana referred to, there will be more and more public reporting on both quality and cost, but there are potential issues about that, and I'll speak to that in a minute. Further levers that I think will drive the evolution of the system is the whole phenomena of the development of these integrated healthcare organizations that I referred to in the beginning, as hospitals and physicians begin to work more closely together, and then those hospitals and physicians, either through direct ownership or through strategic partnerships of one type or another, will work hand in hand with the rest of the healthcare continuum: home care, skilled nursing, acute rehabilitation, all of those pieces. Because the world we're going in, and if the world we're going into, and Don alluded to this, requires a level of clinical, managerial, and financial capacity that really doesn't exist certainly in many physician practices, and frankly doesn't exist in many hospital organizations as well. And so that is what's going to inevitably move things in that direction. I think there's going to be a focus, more and more a focus on individuals as well as whole patient populations. And what I'm referring to there is the interest and the focus on this whole question of patient engagement, largely driven by the convergence of digital and mobile and the development of an incredible array. Frankly, the private equity world is on fire right now with companies that are pursuing one aspect or another of patient engagement for purposes of improving stickiness in the marketing term, but also more importantly, for improving the quality of care and the quality of care that people receive. At the same time that all this is going on, good old-fashioned stuff, the kind of things that places like Cedars-Sinai and UCLA and other academic medical centers have been doing for decades, is going to continue. And we will continue to see the development of I think some pretty remarkable developments with regard to advances in science and medicine that will fuel, allow us to ultimately fulfill the promise of personalized medicine. We're seeing a lot of that in cancer right now, but I think it will move more and more into other fields as well. I think a trend that we've already seen and will continue in the future is increased alignment between payers and providers. In the current world, all of us suffer quite frankly, from the fact that people move around so much from one health plan to another and otherwise. And if that cycle is going to be stopped, at least from my standpoint, I think that's probably only going to stop as a result of better partnerships and more enduring partnerships and relationships between the provider community and the payer community. And then new levels of collaboration among payers, providers, and government. And in that regard, I would just refer to the CMS Healthcare Payment Learning Action Network that was announced, where there's an effort to try to bring together the leading health plans on the commercial side as well as the federal government. So all of those are the levers, and that's, if maybe I can call that the what, then to me the real question is how those things get done, how they get done, and exactly there are a series of decisions that can be made within all of those levers, and how they get done, I think, will have a big impact going forward. With regard to the ACA, there's the Supreme Court decision, which on its face will not have much impact here in California because we do have our own state exchange. But the unknown is the political process that could be launched as a result of the plaintiffs succeeding. If the plaintiffs succeed, that will create a certain amount of instability, and the question will be what kind of political process will play out for possible changes related to tweaking the ACA as a result of it. I think another environmental change has to do with, the ACA rather, has to do with, in this coming year, there's going to be an increase in those eligible for the small group market, moving from 50 to 100. And as that eligibility changes, and the implications of that, I think, could have some significant impact as well. On the public reporting side, from my standpoint, there's really an urgent need to both consolidate and harmonize all of the quality measures that are going on. It's really creating quite a challenge, frankly, and I think is both a barrier to the kind of progress that people want to see, because there are so many disparate measures that are out there being measured and reported on. And frankly, it's also creating confusion in the public. There was a health affairs article published in the last couple months that identifies, I think, some meager number of people who are actually looking at this information and using it for decision making. And that's because depending on which survey you see, you won't see any alignment. You won't see any commonality between which is the best hospital or which is the best physician group. There's a great amount of disparity. With regard to the efficiency measures, I think the efficiency measures are only they're in their gestational phase, I would say. They haven't even been born as a baby or an infant. And therein, I think, is a real challenge, because the development of efficiency measures will call into question a lot of unanswered topics with regard to payment policy and how current payment policy plays out in the delivery system, and how that payment policy, especially government payment policy, gets reflected in commercial insurance prices. An important element in the future is the provider's obligation to achieve the benefits of integration. So consolidation or merger is not the end. That's not the point. Providers have a great obligation to get the yield out of that in terms of improved efficiency and improved quality by achieving greater degrees of integration between the hospital, the physicians, and the other parts of the healthcare spectrum. So the real work is integration, it's not consolidation. And then finally, there are a whole series of things in the policy world that, depending on how those things get implemented, will be a challenge. If there's a theme that I would say in closing, is the need to reconcile new policy decisions with the regulatory mechanisms that are underlying the current environment. I'll leave you with one example. Medicare is very interested in moving to site-neutral payments. That is taking away a distinction between the amounts paid to hospitals compared to freestanding facilities. A noble goal and appropriate conceptually. But if the regulatory environment that makes the hospital environment more expensive than a freestanding environment is not changed, then that will create a much more chaotic environment. And that's just one example of a series of potential regulatory conflicts that I think will need to ultimately get reconciled. Whether those get done in the next 12 months or not, I don't think so. And so that allows us to come back 5 years from now. So thank you.